Assalamu alaikum and welcome to the lecture on drug-induced liver diseases. The material for this chapter has been taken and adapted from Pharmacotherapy Handbook 9th edition by Joseph T. DiPirio and internet sources. I am Shoaib Mohammed, lecturer in the Department of Pharmaceutics, Faculty of Pharmacy, University of Sindh. So this is the outline of the lecture. Firstly, we will be discussing adverse drug reactions. Then we will be discussing epidemiology, characteristics of different types of acute liver failure, risk factors, etiology, dose-related drug-induced hepatotoxicity, environmental hepatotoxins, relative pattern of hepatic enzyme elevation, treatment of the drug-induced liver diseases, management of the drug-induced liver diseases, and finally we will be discussing in detail the paracetamol-induced hepatotoxicity. Firstly, the adverse drug reactions. Now, the adverse drug reaction are effects that are unintentional and that are noxious, and these can occur at doses which are used for the diagnosis, prophylaxis, and treatment. A hepatic drug reaction is actually an ADR, and this will predominantly affect the liver. The drug-induced diseases of the liver are basically the adverse reactions of the drugs onto the liver, and different drugs will produce different kind of the effects onto the liver. Some may be producing the acute effects or the acute diseases, or others will affect the chronic liver diseases. The acute effects of the drugs will appear within a few days, while the chronic effects of the drug, called as the chronic liver diseases, will affect the liver after many weeks. And the intensity of these drugs onto the liver will be different. And there are different pathologies that can occur with the liver, and different types of the drug can cause different types of the pathologies in the liver. The acute liver disease or the acute liver failure is sudden decrease in the functioning of the liver that may be due to various reasons, and the prognosis of the acute liver failure is very poor. That means the determination that what is the causative agents of the liver failure and how much damage has occurred to the liver failure and how can be it managed, this determination is very poor. Now, if this determination is very poor, the prognosis is very poor, the treatment cannot be properly carried out. And because of this reason, the people who are going through acute liver failure, the mortality rate is about 60 to 80% until the patient is having a liver transplant. It is estimated that about 15 to 40% of these acute liver failure cases that are coming to the hospitals are due to the drugs. In the early 1990s, acute overdose with paracetamol accounted for 30,000 to 40,000 hospital admissions, and over half of the cases of acute liver failure were referred to the liver units. Now, in this table, the characteristics of different types of acute liver failure are given. For more clarification, the acute liver failure has been divided into three groups. Number one is the hyperacute, number two is the acute, and number three is the subacute liver failure. Now, these three categories of the acute liver failure has been given different characteristics. The first is the transition time from jaundice to the encephalopathy. That means the time when there is initiation of the jaundice, that is the appearance of the pale yellow color onto the patient, and then there is encephalopathy, the reaching of the liver metabolites onto the liver, and eventually there will be symptoms onto the central nervous system. So into the hyperacute liver failure, the symptoms will lead from jaundice to encephalopathy in about 0 to 7 days. Means within the same day the patient may feel the jaundice to the encephalopathy, or it may occur up to the 7 days. Into the acute liver failure, the transition time from jaundice to encephalopathy is from 8 to 28 days, and in subacute the transition time is more delayed and it may go from 29 to 84 days. The second characteristic of the acute liver failure is the cerebral edema, that is the accumulation of the fluids into the cerebrum. So into the hyperacute liver failure, it is common. In acute liver failure, it is common. However, into the subacute liver failure, rarely the cerebral edema is present. The third characteristic is the presence of the renal failure. Now, why the renal failure is occurring? Now, as the liver is not functioning properly, the liver will not be metabolizing the substances, which include the different metabolites of the body and different metabolic products of the drugs, and these active forms of these substances will be going into the kidneys and putting more pressure onto the functioning of the kidney. And when there is more workload onto the kidney will also move to the failure state. So in the hyperacute liver failure, the renal failure is very early. In acute liver failure, the renal failure come at the late stage, and at the subacute liver failure, it is also appearing and it is at the late stage. Third is the ascites, the presence of the fluid into the liver. It is more rarely present into the hyperacute liver failure, as well as it is rarely present into the acute liver failure. However, it is commonly present into the subacute liver failure. Third characteristic is the coagulation disorder. Now, as we know that the liver is the one of the major organ that is making the vitamin K, and vitamin K is involved into the coagulation of the blood. So the coagulation of the blood into the body will also be affected, and it is more marked into the hyperacute and the acute liver failure, while into the subacute liver failure it is modestly marked. Finally, if we come to the prognosis of these three different types of the acute liver failure, the into the hyperacute, the prognosis is moderate, because we may link to certain level that this drug or this substance may have caused the liver failure, because maybe the patient has been taking a certain type of the drug from a shorter period of time, a new drug has been added to its therapy, and then if the symptoms are occurring of the liver failure, so we can say that this may be the causative agent of the liver failure. So in the hyperacute, the prognosis is moderate, while in the acute and subacute the prognosis is poor, because as you see the symptoms in the acute and subacute may occur from 8 to 20 days or even 29 to 84 days. So there is a much delay, and we cannot judge that which of the causative agents are involved into the acute liver failure. Here the certain risk factors that are involved into the liver failures are given. So the chances of the liver failure due to the drugs will increase if the patient is suffering from pre-existing liver disease, and if the patient is of elder age. In these cases, the chances of the drug-induced liver diseases are increased. The third is the gender. Of course, there is a change into the functioning of the liver into the male and the female. The liver of the male is working or metabolizing the things more, while the female liver has apparently decreased functioning. So the chances of the liver failure will be more into the male. There are of course genetics involved. There are family traits that where the liver diseases are more predominant, the livers are not functioning properly. So in those of the families in which the liver failure is very predominant, they will be more exposed to the drug induced liver diseases. Next is the enzyme induction. If there is, due to any of the lifestyles or any of the other drugs that are used for the other diseases are causing the enzyme induction into the liver, and the patient is also taking some kind of the drug or even those drugs which are inducing the enzymes of the liver, will be causing damage to the liver, and eventually the liver will go into the diseased or the injured state. The common example is the alcohol use of the alcohol. Alcohol initially increases the functioning of the liver enzymes, and if it is taken for a longer period of time at the higher doses, it will eventually cause the liver failure. The next causative agent, the factor which is increasing the risk of the liver failure or the liver injury or liver disease, is the polypharmacy. We are well aware that if the multiple of the drugs are given to the patients, and if these multiple of the drugs are metabolized through the liver, they will be increasing the workload onto the liver, and eventually the life of the liver will decrease. The functioning of the liver will decrease and it will move toward the diseased state. The last factor is the concurrent disease and the pregnancy. As we earlier discussed into the last slide, that if the workload onto the liver is increased, the metabolites will be moving toward the kidney, and eventually there will be kidney failure. So even in certain cases, if the kidneys are not working properly, the metabolites will be moving to the liver, and eventually there will be decrease into the functioning of the liver, as well as certain other physiological conditions, like the physiological conditions of the pregnancy are also affecting the functioning of the liver, and the liver may go into the failure state or the disease state. By mechanism, the drug-induced liver diseases can be divided into the two major categories. Number one is the intrinsic toxicity, also called as the type A, and number second is the idiosyncratic or type B toxicity. These two different types of the mechanisms are further explained onto the next slide. In this table, the characteristics of intrinsic and idiosyncratic hepatotoxic reactions are given. They have been differentiated onto the basis of mechanism, dose dependency, predictability, latency, type of injury, and clinical features. Depending on to the mechanism, the intrinsic toxicity has been divided into the direct toxicity and metabolic abnormality. Into the direct toxicity, a substance or a causative agent will be directly affecting the liver function. However, into the metabolic abnormality, there may be certain changes into the metabolism of the body, and these will be affecting the functioning of the liver. In the idiosyncratic toxicity, there is basically a hypersensitivity reaction. If you go to the characteristics of dose dependency, the direct toxicity is dose dependent. If we increase the dose, the effect onto the liver will be increased. However, the metabolic abnormality and the idiosyncratic toxicity are not dose dependent. We cannot control the dose into these situations, or neither they are depend upon the dose of the drug. They can occur at any dose of the drug or the metabolic substance. Next is the predictability. The direct toxicity, that is the characteristic of intrinsic toxicity, is predictable, because we can say that this agent has caused the damage to the liver. However, into the metabolic abnormality and the idiosyncratic toxicity, we cannot predict that which of the substance has caused the problem. Next characteristics is the latency or the time in which the symptoms will occur. In direct toxicity, the symptoms may occur within hours. However, into the metabolic abnormality, the symptoms may take from weeks to the months. In hypersensitivity reactions, the symptoms may appear within 1 to 5 weeks. The next characteristics is the type of injury. In direct toxicity, the type of injury is mostly necrosis. The substance that is causing the liver damage will be damaging the cells of the liver. They will be causing the destruction of the cells of the liver. However, in metabolic abnormality and the idiosyncratic toxicity, any type of the damage to the liver can occur. This may be necrosis or this may be steatic. The final characteristic is the clinical features. In direct toxicity, there will be acute liver failure. In metabolic abnormality, there are chances of the increased liver enzymes, hepatitis, and jaundice. However, into the idiosyncratic toxicity, that is basically a hypersensitivity reaction, the person will be having fever, rash, eosinophilia, arthralgias, and hepatitis. The liver injury can also be classified onto the type of the lesion. The lesion may be cytotoxic or cholestatic. The cytotoxic lesions have been further categorized into the necrotic or the steatic. In the necrotic lesions, there is damage to the cells. The cells of the liver are destroyed due to the toxicity of the certain drugs or the metabolites of the body. However, in the steatic lesions are the also called as the steatitis, there is inflammation of the fatty tissues into the liver. However, into the cholestatic, the changes into the bile ducts take place and there is no flow of the bile acids from the pancreas and there is accumulation of the bile acids. In this table, the different causative agents that are causing different pathological changes into the liver are given. The first is the hepatocellular necrosis. These agents are causing the damage to the liver cells. These include the paracetamol, propylthiouracil, salicylates, iron salts, allopurinol, dantrolene, halothane, ketoconazole, isoniazid, cocaine, and ecstasy, that is in short known as the MDMA. The second pathology is steatosis, that is the inflammation of the fatty tissues in the liver, and this may be caused by the amiodarone, tetracyclines, steroids, and sodium valproate. The last is the cholestasis, that is the inflammation of the bile ducts and suppression of the bile flow or the stoppage of the bile flow. This can be caused by the flucloxacillin, oral contraceptives, carbimazole, anabolic steroids, and cyclosporin. Now this table indicates some commonly used drugs along with their doses and the duration which is causing the damage to the liver. So first is the paracetamol. Paracetamol is one of the commonly used drugs, and if paracetamol even at a single dose of more than 10 gram can cause the liver injury. The tetracycline, if taken more than 2 gram daily through oral route, can damage the liver, and this risk of toxicity will be increased in pregnancy and if the patient is already suffering from the renal failure. The 6-mercaptopurine that is used in the treatment of the cancer, if taken at a dose of more than 2.5 milligram per kg, can damage the liver as well. Salicylates chronic use of up to more than 2 gram daily can also cause the liver damage. The oral contraceptives, if contain the increased content of the estrogen and if these are used for a longer period of time, can also cause the liver failure. While the iron at a single dose of more than 1 gram can damage or injure the liver. Not only the drugs, but certain of the chemical substances that are used into the industries can damage the health of the occupational workers. These include the arsenic, which can affect the workers who are working in a chemical plants, or even the agricultural workers who are using certain substances which are containing arsenic. The second is the carbon tetrachloride. These are affecting the chemical plant workers as well as the laboratory technicians. The coppers containing substances or the materials are affecting the plumbers, the sculpture artists, and the foundry workers. The dimethyl formamide can affect the workers who are working into the plants and the laboratory technicians. The 2,4-dichlorophenoxyacetic acid can affect the people who are the horticulturist. The fluorine can affect the chemical plant workers as well as the laboratory technicians. Toluene can affect the chemical plant workers, agriculture workers, as well as the laboratory technicians. Trichloroethylene can affect the printers, dye workers, cleaners, laboratory technicians, while the vinyl chloride can affect the plastic plant workers, and it is also even present as a liver pollutant because many of the plants who are using these chemical substances are also spreading the chemical with the wastage of the industry, and these wastages of the industry are dumped into the rivers and the canals. As earlier discussed, the different types of the agents can affect the liver differently and may cause different types of the pathologies. These include the necrosis, cholestasis, and steatosis. These different pathologies will affect the liver enzymes variably. Like the alkaline phosphatase, its normal level are about 44 to 147 units per liter. However, in necrosis, its levels are slightly increased. In cholestasis, its levels are highly increased, while in steatosis, its levels are slightly increased. If we talk about 5 nucleotidase, its normal levels are 2 to 15 units per liter. In necrosis, its levels are slightly increased. In cholestasis, its levels are highly increased, while in steatosis, its levels are slightly increased. Next is gamma glutamyl transferase. Its normal levels are 9 to 48 microliter. Its levels are slightly increased in necrosis, very highly increased in cholestasis, and moderately increased into the steatosis. About the aspartate aminotransferase, its normal levels are 5 to 40 units. Its level is very highly increased in necrosis, slightly increased in cholestasis, and moderately increased in the steatosis. About alanine aminotransferase, its normal levels are 7 to 56 units. Its levels are very highly increased into the necrosis, slightly increased into the cholestasis, and moderately increased into the steatosis. Finally, the lactate dehydrogenase, its normal levels are 100 to 190 units per liter. Its levels are highly increased into the necrosis, slightly increased into the cholestasis, and slightly increased as well in the steatosis. Now here is the treatment of the drug-induced liver disease. Now if the patient's liver has been affected, of course the patient will be having the symptoms of jaundice, and if this symptom is present, then we will go for the relevant drug history, that what medication the patient was taking, and we will also determine whether the patient is having rash, fever, or the eosinophilia, because we also know that the liver injury can also occur due to the hypersensitivity reaction. Now if these things are present, as we say indicated by yes, so we will stop the suspected drug. If we determine that some of the drugs or any of the drug that is causing the disease or the symptoms of jaundice or liver failure, we will stop the drug, and after stopping that drug we will see that whether there is any improvement into the liver functioning or not. Now if there is any improvement into the liver functioning, we will treat the patient symptomatically. Any of the symptoms that are present into the patient will be treated symptomatically. Now if even after the stoppage of the medication, if there is no improvement into the patient, then we will go for the further determinations or further diagnosis, because if after stoppage of the medication the symptoms are not relieved, the basic cause of the liver failure may be something else, maybe something internal pathologies, like if there is increased muscular damage into the patient, the increased muscular damage may cause the damage to the liver as well. And at the first stage, when we were determining the relevant drug history and the presence of rash, fever, and eosinophilia, so if there is no relevant drug history and a certain kind of these symptoms are also not present, so again the drug will not be the causative agent of the liver failure, and then we have to go for the further diagnostic test to determine the cause of the liver failure. Here is the further management if the patient is going through a drug-induced liver disease. So if the causative agent has been found and any of the antidotes are present for that causative agent, so we will use the antidotes. For example, for the paracetamol induced hepatotoxicity, the N-acetylcysteine can be given, and for symptomatic treatment, if there is a hypersensitivity reaction, we will administer the corticosteroids as well. The supportive treatment will be given according to the symptoms that are present into the patient. We can prescribe a certain anti-allergic agents if it is an hypersensitivity reaction. We will maintain the pruritus of the patient as well. If there are any effects onto the coagulation of the blood, the patient is suffering from the bleeding disorder because of the deficiency of the vitamin K, we will administer the coagulants into the blood. We will administer vitamin K to the patient, and the patient will be asked to avoid such kind of the things that will further damage the liver. The pharmacist can play an important role in the minimizing the risk factor of the drug-induced liver diseases. The pharmacist should ensure that the drugs which are causing the hepatotoxicity, they are carefully monitored when they are being prescribed to the patients, and the pharmacist should counsel the patients or their caregivers about the potential hepatotoxic medicines that are affecting the functioning of the liver, decreasing the functioning of the liver, and ask the patient or the caregiver that they must report any kind of the symptoms. We will tell them the symptoms, that these kind of the symptoms can occur if there is liver toxicity, and they must report that if any kind of these symptoms are appearing on them. The pharmacist, or it's the responsibility of the healthcare professional that they tell the patient about the causative agent that has caused the liver damage, and that they should avoid these kind of the substances and be careful in the future. Paracetamol is one of the commonly used analgesic and antipyretic over-the-counter drug, and many of the cases of the liver toxicity have been reported in hospital due to the overdosage of the paracetamol. The paracetamol basically causes dose-related toxicity and results into the centrilobular necrosis. Paracetamol, if given at the lower doses, is metabolized by phase 2 reactions of the glucouronidation and the sulfation. However, at the increased doses, the glucouronidation and sulfation cannot metabolize the paracetamol, and the increased doses of the paracetamol are metabolized by cytochrome P452E1 to N-acetyl parabenzoquinone. The cytochrome P452E1 can also metabolize paracetamol into N-acetyl benzoquinone if it is induced by certain other drugs due to the increased activity of the liver. The N-acetyl parabenzoquinone is a toxic substance, and if accumulated into the hepatic cells, it can damage the liver cells. And even the liver has the ability to detoxify N-acetyl parabenzoquinone by conjugating with the glutathione, which is also present into the liver. However, in certain situations, the levels of the glutathione may become lower so that it cannot detoxify the N-acetyl parabenzoquinone, or even in certain situations, if too much of the dose of the paracetamol is taken, the phase 2 reactions won't be sufficient, the glutathione even will not be sufficient to overcome this overdosage of the paracetamol, and eventually this will result into the toxicity of the liver. The glutathione, which is one of the main substances which detoxifies the N-acetyl parabenzoquinone, its stores can be depleted if the patient is having illness or having starvation, and even the increased amount of the alcohol can deplete the glutathione stores. And if the patient is suffering from the paracetamol toxicity, we can prescribe the N-acetylcysteine or acetylcysteine and methionine as an antidote. These agents will increase the stores of the glutathione, and eventually the toxicity of the paracetamol will be stopped. So this is all about drug-induced liver diseases. Thank you very much for your time.